For a warm introduction, a kind of introduction. Sachin is a dear friend of our from nowadays. Okay, he's quite humble and excellent human being. So I would really like to thank ISA Nanded and the entire team for giving this opportunity. I sincerely appreciate the efforts of Dr. Sachin and the entire team members for organizing these weekly meets on a regular basis. I know it takes really hard work and courage to do all these kinds of meeting on a weekly basis. Before beginning, as we all are aware about the recent shocking incident happened with one of our colleague, Dr. Archana Sharma in Rajasthan, I really like to offer my honest, heartful condolence to her, to the departed soul, and pray Almighty that He provides peace and courage to her family members. This is extremely shocking incident, which really shattered the whole medical community, and I hope her supreme sacrifice open up the new doors of safe and fearless clinical practices in the future. With this background, I'll begin my presentation. It took me for a while to decide the topic of the today's case presentation topic, because these kind of the recent incident, we know that obstetric is really unpredictable branches, and the within second the complication happens. So I put this topic as obstetric emergency or diagnostic dilemma. Diagnostic dilemma is not only for anesthetists but for everyone who are involved in the obstetric emergency management. Disclosure: I don't have any conflict of interest, nor I'm revealing any identity of the person or the place which involved in the presentation. So this case is like 4 or 5 years before it happened to me, and it's like kind of a sudden exposure to emergency, a rare emergency in my career. It was a code blue call from a labor unit in early morning. There was a 36-year-old gravida 2 female. She immediately delivered a healthy baby with a normal Apgar score, and suddenly she went into agitation, desaturation, followed by generalized tonic-clonic convulsion. To control the convulsion, we gave lorazepam 4 milligram immediately. Thereafter, seizures last around 30 to 40 seconds. After the recovery of the seizures, the pulse was around 120 to 130, and it was rising pulse, although it was feeble pulse. Blood pressure was near about 70 to 80 systolic blood pressure. Saturation was barely 80 to 91%, with respiratory rate of 8 to 10 per minute, and this is in spite of providing oxygen supplement around 10 to 12 per minute. Post seizure, the patient was in sedated state, or you can say post-ictal confusion state. So to prevent aspiration, we immediately secured airway and started assisting the ventilation. Meanwhile, the fluid resuscitation initiated. We also ordered noradrenaline infusion, thinking the possibility of any adverse effect like anaphylaxis or any vascular collapse. We also secured extra large bore IV line. While these things are going on, there was a little bit chaos and everything. The obstetrician notified that there is a profuse bleeding because of uterine atony. It's like massive bleeding, you can say that. Immediately, we requested we informed the blood bank to request for the transfusion, massive transfusion protocol. While these things are going on, 2 minutes later, patient suddenly become pulseless. ECG showed pulseless electrical activity. Within few seconds, we started chest compression and cardiopulmonary resuscitation initiated. As patient was already intubated, we continued IPPV with 100% oxygen with controlled mandatory ventilation. In the meantime, labs ABG sent, which further reported as metabolic acidosis and high lactates. There was also evidence of deranged coagulation in the form of deranged PT, INR, and platelet counts. Throughout the CPR, the rhythm was PE only, for which the adrenaline was repeated every 3 to 5 minutes as per the CPR guidelines. And with all these efforts, almost around 30 to 45 minutes, in spite of all these measures, we lost the patient. We could not revive the patient. It was shocking for us, very distressing. On detailed analysis, there was no history of any significant medical or surgical illness to the patient. She had an uneventful previous pregnancy 5 years ago. There's no significant family history pertaining to sudden cardiac arrest prematurely. It was a simple plain induction of labor with term pregnancy. She delivered the baby with a healthy baby with normal Abgar score before the cardiac arrest. Further, the relatives were informed about the sad demise and the possible causes of the arrest, and counseling done for the same. So these kind of incidences are not uncommon for any anesthesiologist or any intensivist. Okay, so the challenging part is to come to the diagnosis, differential diagnosis, because there are n number of causes of sudden cardiac arrest. It can be pregnancy related, like eclampsia, placental abruption, pulmonary aspiration, uterine rupture atony, or pericardium cardium, or a rare cause like amniotic fluid embolism. Or the non-pregnancy related causes like massive pulmonary embolus, venous air embolism, which is a possibility, CVA accident, CVA, transfusion reaction, and myocardial infarction, or any kind of drug anaphylaxis. So there is always a diagnostic dilemma while such incidences happen during the perioperative period, especially when patient is under spinal anesthesia or epidural anesthesia, or even after giving the TAP block. We may never know. It can mimic as a LA systemic toxicity, that is local anesthetic systemic toxicity, or any anesthesia drug related side effect, especially muscle relaxant. Or even the medications, oxytocics like syntocinon, carboprost, can give rise to severe hypotension, anaphylaxis, or even myocardial infarction. Pulmonary aspiration can also mimic all these conditions. But in all these things, typical signs and symptoms may not be present. Some signs and symptoms may not be there at all. So final diagnosis in this case, I hope with the clinical features, seizures, hypoxia, sudden severe collapse, and coagulopathy, most of us can come to a final diagnosis. I would really appreciate if somebody can say the diagnosis, possible diagnosis. If anybody can come to the diagnosis, or anybody can witness such kind of arrest. Dr. Sachin?
Yeah, it's case of sudden CV collapse with coagulopathy.
CV collapse, seizures, hypoxia, coagulopathy.
Yes. Yeah.
Means first time in my life I encountered such kind of collapse, which is very rare for this thing. So any possible, because I cannot see the screen, I cannot see the windows, or I cannot read the anybody's typing.
Yes, nothing to worry. Anybody can raise the
no
voice.
Problem. And I would really like somebody can share after the presentation such kind of incidences if happened with them. Okay, so directly we'll come to our diagnosis. So with all these symptoms or signs kept in mind, we came to the conclusion of amniotic fluid embolism. Okay, so amniotic fluid embolism, because it has given the typical signs, symptoms of seizures, hypoxia, sudden CV collapse, coagulopathy. Although there is no precise definition or criteria for AFE, it is always a diagnosis of exclusion. You have to exclude the diagnosis or the causes, other causes of sudden CV collapse. As such, there is no history of significant past medical or any surgical illness with the patient, which can lead to sudden CV collapse. Coming to details in AFE, amniotic fluid embolism, it's a really rare complication of pregnancy. Okay, the average incidence rate is about 2 to 8 per 1 lakh pregnancies. That is, every 50,000 cases, you will see one case. There's a higher incidence of AFP in cesarean section. So we have to be particularly very cautious while conducting cesarean section. Many of our anesthetist colleagues, they think that cesarean is very easy to manage, but I feel that when the complication we see each and every case as our first case in our life. Okay, so you have to be very cautious in each and every cesarean sections. While in vaginal delivery, the incidence rate is 18 1 lakh. There is a high mortality rate. Previously, the case reports before 2000, it estimated around 80% of mortality. But because of recent advances or advent in equipments, gadgets, the mortality has reduced to 20% also. AFE always presents sudden onset. The presentation is abrupt. You will not realize when it happened, or there's no like earlier signs or this thing that's it is. We can say that the AFE is there. This sudden massive cardiorespiratory collapse. Severe coagulopathy is a pretty prominent features. And many articles they mention that it is a refractory resuscitation, refractory hypotension, that in spite of all the measures, volume load or inotrope, you may end up having bad resuscitation anytime. So no doubt there's significant high morbidity in terms of organ damage, mortality, everything. So AFE is immunologically mediated. Actually, the immunological mechanism is not clear till date. Means since 100 years we have been presenting, or the publications are there, but we are yet to come to the conclusion of why the immunological mechanism has initiated in AFE. The maternal response to fetal or placental antigens. It is the direct response of the fetal or placental antigen given by the mother. That's why the Clark et al. They say that it is more of an anaphylactoid syndrome of pregnancy than the anaphylaxis, than the typical embolism. So previously they used to think that fetal parts, amniotic fluid, squamous epithelium, these are all found in the vessels or after during autopsy, and it is embolism, but it is not. It is mainly immunological mechanism. It's similar to cytokine storm of or COVID. The classical triad, no doubt, in AFE is hypoxia, hypotension, and coagulopathy. Full-blown DIC can be seen in 80% of cases. Seizure can be there in 10 to 15% cases. That can be the outcome of hypotension, hypoxia, etc. But all these typical features may not be present in all the cases. So what are the risk factors? The common risk factors are same, like advanced maternal age, multiple pregnancies, gestational diabetes, polyhydramnias, placenta previa, placental abruption. During operative deliveries also, like induction of labor, operating vaginal delivery, episiotomies, cesarean delivery, the risk factor can be there for AFE. I would like to highlight that DNC. We think that DNC is a very easy process. It can lead to AFE any point of time. Pathophysiology, 3 distinct mechanisms have been recognized. First is mechanical obstruction of the vessels by fetal squamous cell epithelium, amniotic fluid, or debris, which further leads to inflammatory effect on the maternal circulatory system, which further causes immunological mechanism, which is totally unclear why it happens. So pathophysiological, a very nice diagram this is, which can be summed up like whenever there's a uterine breach, the introduction of amniotic fluid and fetal components into maternal circulation causes intense pulmonary vasoconstriction and bronchoconstriction. 2 distinct mechanisms can be noted, which are physical obstruction and liberation of intense inflammatory cytokine release. The inflammatory mediators are also believed to stimulate coagulation and fibrinolytic pathways, leading to DIC. Also, it also leads to severe pulmonary hypertension, which can lead to right heart failure, which further lead to shift of ventricular septum to left heart and further causing left heart failure, which lead to hypoxia and seizure. Are there any premonitory symptoms? Yes, there may or may not be any premonitory symptoms. The common symptoms observed are tingling, cold clammy skin. There can be shortness of breath or distress or feeling of impending doom by the patient. Agitation or restlessness is a typical feature. There can be seizures, as I already discussed, and sometimes only fetal bradycardia. It can only present as a fetal bradycardia. So don't ignore any call when somebody says it's fetal bradycardia. Agitation and restlessness is quite common. So whenever you conduct any cesarean delivery, cesarean section, and patient said that she's feeling something wrong or agitated, never ignore these kind of symptoms. Clinical signs and symptoms, as already discussed. I am repeating these signs and symptoms because these are most important warning signs. There might be rapid worsening of maternal condition, hypotension, severe hypotension, respiratory distress in the form of desaturation or tachypnea, immediate cardiac arrest or arrhythmia. Arrhythmia can be pulseless electrical activity, ventricular tachycardia, ventricular fibrillation, or asystole also. Coagulopathy, deranged PT, INR, platelet, consumption coagulopathy. There can be massive hemorrhage. It can only present like PPH also. And fetal compromise. There is fetal bradycardia or any fetal compromise. So are there any diagnostic tests? No. Clearly, there are no reliable definitive tests. It's just a pure diagnosis of exclusion. So diagnosis criteria as already discussed as acute hypotension, cardiac arrest, hypoxemia, respiratory distress. So only depending on these 4 criteria, you can just rule out other causes and can coin the term as uh, amniotic fluid embolism. Many organizations they propose criteria over a period of time, but the recently American Society of Maternal Fetal Medicine put down the criteria for AFE as sudden hypotension where BP is less than 90, systolic hypoxia of saturation less than 90%, DIC according to ISTH definition, we'll see it later on. Symptoms either during labor or during placental delivery as long as 30 minutes. So it's not like immediately post delivery, it can last up to 30 minutes. So within 30 minutes, anything happen, you can coin it as AFE with the typical symptom. And there should not be any fever. There's no element of sepsis. So this scoring, IST scoring, which we already read in our gynae books, is International Society of Thrombosis and Hemostasis. So to coin DIC in pregnancy, we should have the score of more than 3, which include the variables include platelet counts, PT, APTT, fibrinogen, D-dimer. Total points should be more than 3 to coin as DIC. Coming to the management part, 3-4 basic principles are there. The AFE management is always a multidisciplinary team management. Only anesthetists or only obstetrics will struggle to manage this kind of thing. So we need a good teamwork. This prompt and effective CPR is the key for successful outcome, and rapid evacuation of fetus. Whenever we suspect fetus, the priority is to rapid evacuation of the fetus. Support respiratory hemodynamics to the patient. Fluid management. Fluid management is always challenging in these kind of cases. Vasopressor and inotrops can be given priority over fluid management first. Pulmonary vasodilator, there is quite a good role in pulmonary vasodilators. So coming to multidisciplinary team approach, we need a team of anesthesia expert, critical care, obstetrician, neonatologist, even hematology department, lab, blood bank support is needed, especially when triggering massive blood transfusion protocol. Fetal extraction over 23 weeks of gestation is recommended in such cases. Aggressive resuscitation like CPR is important in such cases. Not to forget, whenever we do CPR for graviduterous patient, it should be left for shift always. Vascular access, immediately large bore venous cannula for fluid infusion is required. CVP line is always needed for inotrop support or any right-sided preload monitoring. If the institution permit or if it is available, pulmonary catheters are always important to monitor left atrial pressure, pulmonary artery pressure, or even cardiac output. Although the recent evidences are against the PA catheter for PA pressure monitoring. Arterial line always useful, accurate BP monitoring, taking out ABGs, multiple blood sample collection. Urinary catheter output measurement. We all know that best measurement for tissue perfusion is urinary output. So you have to have hourly urinary monitor in these cases. Crystalloid use. There's a role in crystalloid use, but you have to use it judiciously. You cannot just try pouring crystalloid because there's a setting of coagulopathy also. It should not interfere with the coagulopathy. That's why inotropic support at the initial stage is recommended. Vasopressors, early initiation, as already mentioned. So most favorite one for all of us is noradrenaline, although dopamine, dobutamine, adrenaline, even vasopressin can be tried. Combination of vasopressor is also important. So with all these efforts, the target mean arterial blood pressure should be 60 to 65 mm of Hg. Hourly urine output should be minimum 40 to 50 ml of hour. Your PaO to FiO2 ratio should be maintained at 250. Sometimes you can use inhaled nitric oxide if it is available to reduce the right ventricular afterload. So difficult part in these cases are managing coagulopathy. Problem not only occurs because of availability, but is the duration of duration at which they are available. Because if when once you start ordering by cross matching and everything, it takes at least half an hour, 45 minutes. So it is always challenging to arrange the blood at the right moment. Whenever blood is arranged, you have to give red blood cells, FFP, platelets at the ratio of 1:1:1 until you control the bleeding in a proper manner. There is role of cryoprecipitate, which is factor 7, 1 milliband factor, and fibrinogen to maintain fibrinogen levels to more than 200 milligram per deciliter. There are some evidences on tranexamic acid, which act as fibrinolytic. Also, if thromboelastogram is available, we can use that for appropriate use of blood product. The recent lot of cases they use ECMO as a last measure, especially in refractory cardiogenic shock. So whenever there's CPR going on, and if you have the facility of ECMO, there's always a recommendation to put femoral, arterial, and venous sheath in anticipation to start ECMO for refractory cardiogenic shock. Also, intra-aortic balloon pump also tried, which gives rise to a myocardial perfusion, good myocardial perfusion. In some cases, even right ventricular assist device have been used successfully, and the maternal outcome is quite good in this way. Obstetric maneuver, in spite of all these measures, if bleeding is still not under control, there are some maneuvers like uterine artery ligation or circumferential B-Lynch, something like Heyman or Pereira compression sutures. Or in case the massive hemorrhage or atonic uterus, you have to go for emergency hysterectomy. It's quite distressing to see the patient when, especially patient is on ventilator or patient even more mortality. It's quite distressing for family members also to go through this phase. So pain and palliative consideration to be there. Especially if managing patient on ventilator, you have to manage pain and anxiety of patients. End of life care, especially during mortality. That's why the role of palliative critical care in this case is foremost. Family communication and counseling is important because this is distressing for everyone. Most of the family members, they go in a stress disorder. In such cases, referral to support group is also important, because we have gone through it. It's very difficult to counsel the relative at the last moment. They really don't accept this mortality, sudden mortality, because their patient was healthy before the incident and suddenly collapse. It's very difficult for us to counsel also and convince also the probable causes. So my take-home message is very clear that whenever this such kind of collapse occurs, there has to be high index of suspicion of AFE, and should be considered where the obvious cause of collapse is not identified. Although it is very rare phenomenon, but don't think that it will never happen in your entire life. It can happen anytime. So be ready for this refractory, you can say refractory CPR. You have to be really aggressive managing cases. Early recognition and aggressive management of the patient with resuscitation improve the survival of the long-term morbidities. So that is the key: early recognition and aggressive management. And you have to have teamwork. You cannot be like Superman that I am anesthetist, I can do everything. I can do intubation also. I can do at the same time central line monitoring. I can do. So no, you have to have a good code-blue team, because it has to be organized in a proper manner. So otherwise, you will end up losing the patient. Coordination between multidisciplinary team is the key for successful maternal and fetal outcome. That's why you have to train your hospital staff how to manage. That's why it is always better to conduct one such trial whenever such thing arise. You have to see whether your team can perform or not, whether each and every thing is organized, medication organized, blood bank is properly called, whether they are storing proper blood or not. They know their CPR well or not. Your machinery equipments are in proper place, because LDR is a place where you will not find everything which is needed there. Okay, and shifting to OT or any IC is also very, it's not an easy job for that. These are my references, quite nicely written by both the authors, and thank you very much. I would really appreciate if somebody can share their experiences. This was my experience. I don't know we have done in a better way or not. It was unfortunate for a patient not to survive, but it was kind of experience which I really would like to share with you. So I really like, rather than questioning, I really like somebody can share their experiences in this regard, because we really don't publish our data. What I think that whenever such cases happen, even we did not publish this data because of some constraint. So I would appreciate if somebody can share their own experiences of sudden collapse and AFE if there are. Thank you very much. Any question are welcome, any suggestions or any experience are almost welcome. Sachin?
Hello. Very
Sachin.
nice presentation.
Yes, Sachin.
Very nice presentation. I'm thinking of AFE, and you started discussion on that. I want one question on this. You said this is a antigen related process.
Mechanism. Yes, yes.
Yes. So role of corticosteroids in these cases?
No, I have checked a lot of articles, but there is no. Some articles they mentioned, but it's questionable. There's no problem is because it is rare entity. There are no hard and fast meta-analysis or something. So corticosteroid, I have not seen in any of the literature.
Okay. Okay. One question raised by Dr. Abhijit Nair has raised hand. Please,
Abhijit Nair is our boss.
Hello, Pavan. Pavan,
Yes,
good evening. Sachin, good evening. Nice presentation, Pavan. First of all, I really appreciate because your presentation, because people, they don't dare to present such cases where there has been mortality or where there has been a negative outcome. So it really takes guts, and you take it as a learning experience, and you have shared so much information supported by recent evidence and so on. I really appreciate that, and your team, yourself, you did a good job. That was very unfortunate what happened, what we heard, but then these are all take-home messages, and in our specialty we are supposed to learn from. This was not a mistake. Basically, there was no mistake over here, but this is something that makes us ponder more, think more, and do better subsequently. So thanks for sharing your experience, Pavan. Great.
Thank you, Abhijit. Always welcome. You are our boss and guiding force for us.
Yes. Pavan, please check in messages. There are a lot of appreciations and.
Okay, I'm checking. I would really like if Paliwal sir is there, if he can share any such incidents if happened, or any corrective measure or any suggestions, or other stalwart.
Yes, you can able to read, no?
Yes, I'm reading. Okay, good.
Yes. Yeah, JC madam just explained that AFE is almost always fatal, so it is diagnosis by exclusion. Horrible experience to have. Excellent presentation. Okay.
See, problem is this kind of things we just read during our exams. Even I know that we had a short note on this thing, but when it really comes as a sudden shock. It is like that short note is not sufficient to manage the patient.
Yes.
Okay, and we always think of eclampsia, pre-eclampsia, or PPH, this kind of stuff. We never think that
Yes.
this can happen anytime. Okay, so and the surprising thing is all eyes are on anesthetists that do something. That see the importance of anesthetist comes here. That obstetrician or any of the this thing, they don't care who is there. The important person at that time is anesthetist for them. So they rely so much for anesthetist management. So we have to be really like on tip of our this thing.
Okay. One of my OBGYN friend having same incidents while delivering a baby at his nursing home. So and that time baby delivered and the patient sudden collapse. After almost he did every delivery in ICU. After that, I think
Correct.
he did that thing up almost up to 2 to 3 months. 10 to 10 deliveries he delivered in ICU only, and after that that shock went off.
Yes, yes, that's right. That's
Really horrible, and I seen him personally that time.
true. Anyway, good audience. I appreciate the efforts. I appreciate the messages.